Hi everyone, welcome to Raaonline teaching program. So today we are going to discuss about the approach to congenital heart disease. Okay, so today's session is going to be like as a broad-based general session where how to approach a child with a congenital heart disease. So as you all know, congenital heart defects have a wide spectrum of severity in infants, like almost 2 to 3 infants in per 1000 newborn has been symptomatic with a heart disease. So if you see the prevalence of the heart disease, 0.8% of the live births are having the known to be having the congenital heart defects. But even the incidence is still higher in the stillbirths, that is almost like 3 to 4%. So in stillbirths, if you see, so the incidence if you see in stillbirths, it is even more higher, that is around 3 to 4%. And in spontaneous abortion, spontaneous aborted fetuses, if you see, this incidence is even more higher, that is 10 to 25% of the aborted fetuses will have some form of congenital heart defects. And one live births, it is supposed to be 0.8%. In premature infants, apart from the patent ductus arteriosus, that is PDA, approximately 2% of preterm infants will have some other form of the congenital heart defects. So if you see, it has a wide spectrum of severity, and most of the congenital heart defects will be detected in the first week of age, that is almost like half the percent, 40 to 50% will be detected during the first week of age, and rest of the like 60% will be detected within the first month of age. Despite the advances in the treatment, like more corrective surgeries has been happening now and more palliative surgeries been attempted, even the survival rate has been increased. But even then, congenital heart disease is supposed to be one of the leading cause of death in children associated with other congenital malformations. So coming to the etiology, like what is the cause, underlying cause for the congenital heart diseases to happen, still the cause for the heart defects is still unknown. Particularly many cases of CHDs are multifactorial, that is, it has some connection with a genetic predisposition and some amount of environmental stimulus which has not been identified has been have a connection with the formation of the congenital heart diseases. And in particular, if you see, some chromosomal abnormalities have been associated with the incidence of congenital heart diseases. For example, if you see in trisomy 21, that is common chromosomal abnormality, that is a Down syndrome. In trisomy 21 is associated more commonly with the endocardial cushion defects, that is atrioventricular septal defects. So trisomy, it is associated with almost like 50%, more than 50% of the patient with the trisomy 21 will have some type of cardiac defects, like either it may be ASD, VSD or AVSD. And in case of Turner syndrome, if you see, in Turner syndrome, it is associated with the almost like 40% of Turner syndrome children will have some amount of cardiac diseases like coarctation of aorta or mitral valve prolapse. These kind of cardiac defects, congenital heart defects will be there. And another common syndrome is the trisomy 13 and 18. So even in Patovo and Edwards syndrome, that is trisomy 13 and 18, if you see, more than 90% of the children with this trisomy have associated cardiac defects, almost 90%. So far the chromosomal abnormalities associations has been identified. So these are some of the genetic syndromes associated with the congenital heart diseases. Just I have taken some few syndromes which are more common associated with the cardiac lesions. If you see, the foremost is the DiGeorge syndrome. The name itself, it is velocardiofacial syndrome. So the cardiac abnormalities are tetralogy of Fallot or interrupted aortic arch or tricuspid atresia or ventricular septal defect. So in case of familial ASD, with or without heart block also is there. And another common syndrome is the Alagilli syndrome. Usually the bile duct hypoplasia and right side cardiac lesions are more common in the Alagilli syndrome. So right side cardiac lesions, in the sense there will be peripheral pulmonary hyperplasia or pulmonary stenosis or tetralogy of Fallot. And there is another Holt-Oram syndrome that is associated with the limb defects, and it is connected with ASD and VSD. And as I already mentioned, Down syndrome, more commonly this atrioventricular septal defect, that is endocardial cushion defects, is more common. And another syndrome is a charge syndrome, where again septal defects and tetralogy of Fallot is more common. And Williams syndrome, the unique cardiac abnormality is the supravalvular aortic stenosis and peripheral pulmonary stenosis. And in Marfan syndrome, which is a connective tissue disorder, where there is a aortic aneurysm, aortic root dilatation and mitral valve diseases is associated with the Marfan syndrome. And this I already mentioned, like Turner syndrome, Pato and Edwards syndrome. And another two syndromes like Cradock-Chatt syndrome and Cattay syndrome are associated with the septal defects. So if you see, more commonly in almost all the genetic defects, ASD, VSD, PDA and tetralogy of Fallot remains common in almost all the congenital heart defects. So, having read about the etiology of congenital heart diseases, now we are going to see about how to evaluate, like stepwise, how will you are going to evaluate a child with a congenital heart disease. So, regarding the stepwise approach, if you see, it is basically the congenital heart defects are like we have to approach the child systematically. So, broadly it is done under three major components, that is any congenital heart defects are broadly classified into two types. That is, you all know, it is a cyanotic heart defect or acyanotic heart defect. So, by the presence or absence of cyanosis, it has been differentiated into cyanotic and acyanotic heart defect. So, this can be detected by physical examination, also by the saturation measurement by using the pulse oximeter. So, the cyanosis can be seen by the physical examination and also by the pulse oximeter reading, that is saturation monitor. Okay. So, physical examination, where you all look up for the cyanosis, mainly in the tips of the fingers, tip of the toes and in the mucous membrane and all, you can look for the cyanosis.